All right, good evening everyone and welcome to Take Charge for the month of May 2014. We're very fortunate today to have a speaker with us, Dr. Mira. Mira is an optometrist in private professional practice in downtown Toronto for 30 years now, which is fantastic. She knows her stuff. She's got an extensive involvement in the Ontario Association of Optometrists, the Vision Institute of Canada. She's been president of both bodies, and she's still involved with both those organizations in other roles and capacities. She's in the media an awful lot as an expert talking about vision and aging and eye health, and that's actually going to be our topic today. We're all getting older. We talk about what happens to our hearts and the rest of the body as we age. Well, today we're going to be very fortunate. We're going to find out what happens to our vision as we age, and what can we do to try and make sure that we age with our vision as gracefully as possible. Dr. Axe, all over to you. Thank you.
Thank you. Thank you very much. First of all, I would like to thank Cheryl Miller for inviting me to take charge this evening. It is a pleasure and an honor to be here. And I want to thank all of you for coming out and listening to me talk on this rainy night. I don't know if Cheryl knew when she was thinking of this topic in November that it turns out May is the National Vision Health Month. So kudos to all of us, so being on topic and doing what we're supposed to be doing, and that is taking charge of our health and learning about eye care and why it's important for a lifetime of living well and learning. So I'm going to start to talk to you a little bit about the eye, and I'm going to take you through the eye from the front of the eye all the way to the back of the eye, and I've given each of you a handout on that, so you should be able to follow along with me. I'm not going to be talking from slides. I'm just going to be talking exactly the way I would in an examination room to each and every one of my patients. I'm then going to talk a little bit about the different functions of the different parts of the eye, paying special emphasis to those changes that occur as we get older and what to expect as being normal, but also what to look for when it isn't exactly what is normal aging process. I'm going to talk about specific diseases, including glaucoma and macular degeneration and cataract, and systemic diseases as well, a little bit about diabetes and inflammatory diseases and the effects those have on the eye. And then I'm going to talk very briefly towards the end of tying the whole thing together about some modern technologies that are hopefully coming our way that perhaps some of you will be already aware of, and some of you may not. I would like this to be as an interactive talk as possible. We're going live, but questions that come up along the way, please do, because that's going to make our topic so much better. I'm going to start now. I hope every one of you has that little handout that I gave you. I'm going to ask a question. First of all, how many of you here in the audience today have had their eyes examined within the last 12 months? Just a show of hands. Look at you go. This is just awesome. Almost everybody, which is wonderful because that means that you've already taken the very first step. You're having your eyes checked on a regular basis. Some of you perhaps even see their eye care practitioner, their eye doctor, whether it's an optometrist or an ophthalmologist, more frequently than that. So annual checkups are recommended generally, but many people, in fact, see their eye care practitioners more often than that. So if I would go by a show of hand, for those people in this audience that see their eye doctor more than once a year, can I get a show of hands there? There's quite a few of you. And as soon as I see those hands, I realize and understand that you're either being actively treated for some disease or specifically being monitored for the possibility of some specific condition or a specific disease. And again, kudos to all of you for being proactive and following up and looking after your eye health and vision. So let's take a look at this. When you look at the eye, on that diagram that you have in front of you, one of the things that is missing from the diagram is actually some very important structures. And that has to do with the eyelids and the eyelashes that protect our eye from the outside world. So the first line of defense that the eye has from the outside world is actually the eyelashes and the eyelids. You would think of this as something not particularly important to the eye health, when in fact it's all very important, and the eyelashes play a crucial role in maintaining the integrity of the tear film, which is behind the eyelashes. Why is it so important? The eyelids have glands in them, and those glands secrete oily liquids. Some of those glands are called meibomian glands, and they secrete an oily liquid called meibum. And their job, those glands and the oily liquid that they secrete, is to maintain the lipid layer of the tear film, so to make it nice and moist and to maintain the eyelashes and eyelids as being nice and moist. There are other glands in the eyelid area. The one big one in particular is called the lacrimal gland, and it secretes the watery part of the tear film. And there are many, many small glands, some called the glands of Mole and the glands of Zeiss, probably named after a Dr. Mole and a Dr. Zeiss way back when. And they secrete various mucins and proteins that make up the very complex tear film that we all have that protects our eyes. So those glands are there in the eyelashes and the eyelids. The eyelashes are also there for a specific reason. The eyelashes sweep away the debris that comes at us. The blink reflex is particularly critical in making sure that the tear film stays stable and it protects your cornea. The eyelashes can be a problem sometimes. As we get older, the eyelids sometimes can become a little bit more lax. They become thicker, and they may involuntarily actually either turn away from the eye or turn in towards the eye. In particular, if they're turning in towards the eye, that could mean that the eyelashes are actually scraping along the front surface of the eye. And if anybody's ever had an eyelash fall in their eye, I'm sure we all have, it's actually fairly painful. But if you have that feeling with every single blink that you take during the day, that becomes a very important thing that has to be handled as quickly and as safely for you as possible. And it could be as simple as taking a tweezer, not you, the eye doctor, under a microscope, and removing that eyelash that's causing the problem. And sometimes that relief can be immediate, and you're very thankful that somebody was able to deliver that very small step in making your vision and your eye health better. The eyelids by themselves can actually become fairly inflamed. They can become red and itchy and flaky, and when those flakes drop off into your eyes can become incredibly uncomfortable. And that situation or condition is actually called blepharitis. Whenever we have an itis at the end of a name, essentially that means that there's an inflamed part that we're referring to. And the eyelids, when they become inflamed, they drop these little particles of the skin that flakes off into the eye. It's almost like dandruff on the eyelashes, and it's incredibly uncomfortable. It's treatable. It's treatable, and it's managed relatively well, but it takes work and time on your part to do it. Sometimes it involves hot compresses. It may involve antibiotics or lid wipes to keep the eyelashes nice and clean. So I've briefly touched on the tear film a little bit, but actually the tear film is the next subject matter that I'm going to talk about, and we haven't even gotten to the globe picture of the eye, because before we even get to the eye, there are certain things that we have to talk about. So the lashes was one thing, the eyelids is another, and now we're going to talk about the tear film. Are you starting to get the idea that the eye is a really well-protected organ? It actually is a very well-protected organ. It's got a whole bunch of barriers between you and the outside world. When I graduated from optometry 30 years ago, the tear film was just this nebulous liquid that we had in front of the eye that was divided into a few layers that was responsible for this very vague function of protecting the eye. We have since found out that the tear film is incredibly complicated. It needs to be maintained in a manner that makes it uniform, that allows it to resurface with each blink, and that it provides excellent vision. When the tear film breaks down, if your tear film isn't there, the first thing you notice is blurry vision. You don't see well when the tear film isn't there. So there isn't a pair of glasses that I can put in front of you to make you see clearly if your tear film isn't uniform and there in place to keep everything in focus. I'm going to go back a little bit to the blinking as well again, because if you think about how often we blink, it's 17, 18, 19,000 times a day that we blink. And those eyelids have to go over that tear film and resurface it every time. You can just imagine if that tear film started breaking down, your vision becomes like the vision on a piece of glass that has been smeared with Vaseline. It's just not clear. And there are no glasses that I can put in front to make it clear. So the tear film is one aspect of how well we see. It could be that the eyelids are not properly aligning with the globe of the eye or the actual eyeball itself, and that will affect how you will see as well. Or you may actually have some obstruction in the tear film producing glands, in particular in the lacrimal gland, in which case it can't allow the tear film to flow through the gland and to add it into the whole complex that the tear film is. So hopefully you have a better idea now what I'm talking about when I'm talking about the protection of the globe. And we're finally going to get to the first part of it, and that's the cornea. So the cornea is the part of the eye which is the window through which you see. It is totally transparent, or it should be totally transparent. It is when we're born. As we get older, the cornea actually loses some of its transparency. It becomes less clear. The clarity degrades for a variety of reasons. The main reason that it degrades is actually just natural degeneration of the cells of the cornea. I don't want to harp on this too much, but 30 years ago when I graduated from optometry school, there were exactly 5 layers to the cornea. We have subsequently, in the last 18 months or so, discovered there's in fact a 6th layer. So they didn't teach me everything I know at school. They're still teaching me things along the way that are new. That 6th layer of the cornea actually is called the DUA layer, the DUA layer, and it's critical in those patients who are undergoing corneal graft. Is everyone in the audience familiar what a corneal graft is or why it's done? A corneal graft is an actual replacement of the cornea. A donor cornea is made available, and a cornea that has been diseased by various processes, including keratoconus or some major trauma, such as an acid burn or a burn of the eye or damage to the cornea, has that implanted cornea put right in place of the diseased cornea, and that's a corneal graft. Many corneal grafts in the past would fail. The donor and the match wasn't just right, and those corneas didn't take, and there would be huge problems. They figured out that there was a 6th layer of the cornea called the DUA layer, that if that layer isn't intact and healthy, the graft will fail. So it's very important that we think about everything that we know today and think about the possibility of everything down the road. How many more corneal grafts will be incredibly successful if they now know to look for something very, very thin, very, very microscopic. We're talking 10, 12 microns, but incredibly important for the health of the cornea. So the other thing that happens with the cornea over time is not just that it loses some of its luster or some of its clarity, is that it loses its ability to fight off infection as well. So corneal infections and infections of the general front surface of the eye become more frequent as we get older as well. And one of the reasons for that is that the cells on the front surface of the cornea break down. The epithelial cells, the very first row of cells that are on the front part of the cornea, start being fewer and fewer in number, as well as the endothelial cells. Those are the cells that are at the back of the cornea. They become fewer in number so that germs, pathogens, bacteria, various bugs can get in there and cause an infection. So it increases the risk of infection as well. The cornea has become more fragile, so that any kind of trauma or an injury becomes more difficult to heal. Fortunately, as we get older, and here's a little bit of plus, corneas become less sensitive. So sensitivity of the cornea actually becomes a little bit lower, which is good and bad, because if you have injury to your cornea or you have a corneal infection and you don't feel it as much as you should, perhaps you will delay taking the steps to have your eyes checked and having care given to you. Right behind the cornea, you're going to see a structure which is labeled as the iris. Now, the iris is the colored part of the eye, and it is responsible for focusing. It is responsible for making the pupil small and making the pupil big. There are muscles in the iris, and those muscles are called the dilator. Obviously, it's going to dilate the muscle, the iris, and then the sphincter, which is going to constrict the pupil down to small. So those muscles, as we get older, become more lax. They become more tired. And as you look at older people, you will definitely see that their pupils are actually a little bit smaller than somebody who's very, very young. You look at young children, and their pupils are really large. That's because their muscles are in proper balance. And as we get older, that imbalance occurs, and the pupils become a little bit smaller. And that could be good and bad. So if a pupil becomes smaller, what happens is that we actually can increase our depth of focus. We see better. However, as we get older, the ability of the eye to focus light becomes less, so that doesn't help us particularly. We may become more light sensitive as we get older, particularly to glare. So having a large pupil would make you actually more sensitive to it. A smaller pupil perhaps protects you a little bit. Unfortunately, if you are developing cataract directly behind that small pupil, that cataract will annoy you and bother you a lot more than somebody who has larger pupils and their cataracts are in the center. So we're finding that there are pluses and minuses to everything. And I'm going to hopefully come back to a lot of individual variability, a lot of things that one individual may be quite bothered by, another one not. Humans are incredibly variable, and there's going to be differences amongst all of us. If you're following along in our diagram, the next body that I'm going to talk about actually is the ciliary body. The ciliary body is the part of the eye that is responsible for moving ligaments and for attaching to the capsule which holds the lens. The ciliary body is also the part of the eye that produces the liquid in the eye that is known as the aqueous humor, and we're going to cycle back to that liquid later on. Right in the middle, you will see a lens, and the lens right behind the iris is called the crystalline lens, and that part of the eye is the structure that focuses light on the retina. When we're born, that lens is totally clear and transparent and is very flexible. It moves very easily. When the ciliary muscle contracts, the ligaments pull on the lens, and the lens bends, and we focus. This is where I get to use that old saw about how youth is wasted on the young, because when you're young, you do not appreciate that you have this amazing lens in your eye that is autofocusing all the time. As we get older, that autofocusing mechanism gradually slows down to the point where it actually stops. So initially, it's just a slowing down. When you pick up something small to read close up, you go, oh, I can't read it here. I'm going to have to read it over there. That's the first stage of what is called presbyopia. That's the fancy term for not being able to focus things close up and requiring to push them away. And it could take up to a decade for that to completely go away. At first, you may just experience a little bit of what we call a lag of accommodation. You just slow down. You can focus, but it takes you longer. You pick up something, you look at it, and it takes you a little bit longer to focus. The other thing that happens, of course, almost simultaneously is that the adaptive mechanism to refocusing from near to far and far to near also slows down a little bit. Really annoying. And many patients in their 40s and 50s come into my office, mostly in their 40s, having never experienced like this, anything like this, and they think they're dying. They think this is the end of the world. They will never, ever be the same again, and yeah, it is what it is, and we move on. Now, let's get back to the lens a little bit. The lens inside the eye, when it starts to become opaque, will filter light. So one of the functions of the lens is to filter light anyway. But as the lens ages and becomes older, it becomes more and more yellow. Think of it as Tupperware. You bought some Tupperware. It was really clear and transparent. You forgot about the Tupperware. You put the Tupperware someplace in the back of a drawer. Years later, you pull out the Tupperware. Is it still clear and transparent? It is not. It's grown yellow. It may have some heart pieces attached to it. It may not be transparent all the way through. There may be actually some opaque pieces to it, which is what happens to the lens inside the eye. By definition, we call that a cataract. Most cataracts occur in our 60s, but cataracts can occur at any age. They can be, in fact, congenital. There are some genetic families, genes that carry the dominant gene for cataract, and you can be born with a cataract. You can develop a cataract as a young person, perhaps even as a result of trauma or injury. That can trigger a cataract or an opacity of the lens inside the eye. You may take some medications. Those medications could be anti-inflammatory medications like steroids, and they can increase or speed up the development of cataract inside your eye as well. So cataracts can come from any number of causes, but the number one cause for it likely is just age, just the passage of time. And the only question is, where on the continuum are you, and how much is this cataract bothering you? So when a cataract bothers a patient a lot, it could be bothering them simply because the cataract is acting like a filter. So it's absorbing light, and this has happened to most of us at some point. You pick up something small, it doesn't have really good light on it. It could be a map, a bottle of instructions on some medications, and if the light isn't on completely in the bathroom, you have a great deal of difficulty reading it. You put the light all the way on, you shine it on the object, and all of a sudden the ability to see becomes better, with or without your glasses, depending on whether you're needing glasses. So the cataract, the opacity of the lens inside the eye, is first and foremost acting like a filter. It's filtering light out, so you need to put more light on the object to see it. That's the first step that occurs in the cataract. On that continuum, if that cataracts continue to develop, it will become opaque to the point that no amount of light will allow you to see letters as clearly as you want, particularly at the distance. And of course, that is the point where if that 20/50 line that you need to be able to see on the chart to drive isn't reached, cataract surgery actually becomes a serious option for you. And it is one of the most frequently performed medical interventions out there. How many of you here have had cataract surgery already done? Wow, look at you. Bionic eyes. Intraocular lens implants are an amazing thing for most people most of the time. It is the most frequently performed medical intervention, probably with one of the highest success rates out there. And some of the intraocular lenses recently have actually developed some very advanced technologies to them so that they can correct for both near and far, and some of them can actually correct for astigmatism. So there are some ways of doing this better and better over time. The procedure used to be a very complicated procedure that took a lot of time away from work and required a long stay, sometimes even in the hospital. And now it's minutes. You go in the morning, you should be home for lunch. Not that there aren't complications. Things can and do go wrong. For the most part, though, however, most people do get through this procedure fairly well. So I want to go back a little bit to the lens, and I want you to stay with this for just a little bit and talk about the fact that the lens inside your eye absorbs blue light. It absorbs ultraviolet light, and it absorbs blue light as well. One of the reasons that it absorbs blue light is that it yellows with age. So a yellow pigmented structure is going to absorb the blue light. So it's almost like it's protective in some ways. It's absorbing at least the visible part of it. The invisible part of it is not protective at all. And we'll talk about this a little bit more, but the invisible part of light, the ultraviolet part of the light below 400 nanometers, is actually damaging to the eye and is one of the risk factors for developing cataracts. I'm going to talk a little bit about the neck structure that you see on your, and by the way, if you have questions, please don't forget, you can interrupt anytime. But the neck structure that you see here on your diagram is the vitreous humor. About 80% of the eye is actually this jelly-like structure that keeps the globe of the eye intact. The jello of the vitreous humor is a very uniform substance when we're first born, but it goes through a process of shrinking. I believe the fancy term is syneresis. And because it's jello, I want you to think of it like a bowl of jello. If you make some jello, and here we go again, you put that jello in a bowl and you forget about it. You put it at the back of the fridge and you pull it out a week or so later and you realize what's happened to that jello. That jello has kind of clumped, pulled away from the sides. It's no longer totally uniform. Bits and pieces are a little bit thicker. And that's what happens to your eye over time. And that kind of vitreous liquefaction, which is just a fancy term for saying that the whole thing clumps and pulls away, can be called a vitreous detachment. And a vitreous detachment is something that many of us have perhaps experienced. One of the things that you see when you're having a vitreous detachment is floaters. Floaters are little bits and pieces of tissue which float in the jello of this vitreous, and you see it imaged as if it was in front of you. They can appear like strands. They can be like little wiggly, jiggly bugs. They can be gray. They can be black. They can be multicolored, transparent, translucent. And sometimes they're very annoying because they're right there, right where I'm looking. That's where it is, and you can't make it move. If you actually try and look at it, you can't look at it because it's moving with your eye. It's going over here. It's like your personal satellite. It keeps orbiting around you all the time. Annoying, and patients often ask me, can't you just vacuum that sucker out somehow? No, I'm afraid not. You're there and you have it with you for a while. Sometimes what happens over time is that they actually settle down to the bottom part of your eye. Gravity does its work. For once, it's a good thing. And when it does that, they're outside of your visual axis. So when you look straight ahead, you're not looking at that floater. The floater is down below. You're less aware of it, so it's no longer as annoying as it was when it first appeared. There are certain conditions in the eye that predispose this vitreous kind of pulling and syneresis. One of them is actually diabetes. Show of hands, how many folks do we have in the audience that have diabetes? Yep, there we go. So one of the things that occurs in the vitreous jello is that you have a little bit more glial cells or more protein in the vitreous. And it tends to pull and tug a little bit more and give you more floaters and make you more unhappy. But know that what's happening to you is really just on a continuum with everybody else. We're getting to the part of the eye next that is actually probably very important for all of us. We're going to talk about the retina next. And one of the ways that I like to talk about the retina is to circle back and talk about the eye as a camera. Think of your eye as a camera. The camera has an aperture. It's the f-stop. It's the pupil. It opens and closes and focuses light, gives you depth and focus. It has a lens, the lens that we talked about that focuses the light. There's a body of the camera that houses everything. And at the back of the camera, you have film, or at least in the olden Kodak days, you have film. So stay with me here. We no longer have that. But the film is where we develop the image. The film is where the image is actually created. So the retina is the part of the eye where the image is created. Now, how is it created? It's created by the use of a whole bunch of cells, millions and millions of cells, which are called photoreceptors. We all have them, and those photoreceptors are basically divided in two groups, the rods and the cones. The cones are the photoreceptors which are responsible for your color vision. We have lots and lots of them right in the central part of the retina, and they're responsible for the highest resolution that we can have. So if you were to think of an HD TV with lots and lots of pixels, that's the central part of the retina, lots and lots of cones, giving rise to our central vision, the highest level of clarity that we can have. As we go away from the center of the retina, more towards the periphery, we have a higher concentration of a different type of cell, and that cell is called a rod. Those rod cells are responsible for our black and white vision, and they're more into the periphery, which makes a lot of sense. The way the eye was designed, that at night, when luminance is low, our pupil dilates, and when our pupil dilates or becomes bigger, we're using more of the periphery of the eye, where we see more black and white, and that's why we see at night, at least somewhat, right? Our nighttime vision is more controlled by the rods, and our daytime vision or color vision is controlled more by the cones. So what we have at the back of the eye is the retina. Many, many layers of cells, but the most important one that I want you to think about is these photoreceptors, the rods and cones, and what is directly behind those cells. What is directly behind the rods and cones is a layer of cells called the RPE. What that stands for is retinal pigment epithelium. Think of that as the backing of the camera. That's where that film of the camera is situated, and if everything goes well, if that RP is there to support the rods and cones will continue functioning. However, this is the part where we're going to get into what happens to the retina as we age. One of the most metabolically active structures in our body is the retina. What I mean by that is that the retina requires a lot of oxygen. It consumes a lot of oxygen, it consumes a lot of nutrients in order to function properly. When you need oxygen, when you consume oxygen, you have oxygen metabolism happening. What happens next is that you have the natural release, the normal release of free radicals. Have folks heard about free radicals? You've talked about this, I'm sure, many, many times, but in the retina, free radicals can certainly cause a lot of damage to the structures of the eye that are the most important to us. If you don't have film at the back of the camera, the back of the eye, you can't create the image, which, by the way, on the retina is upside down, just FYI. The way the image is on the retina is not the way you see it. When it comes in and it's actually put on the retina, it's upside down. It doesn't, yeah, that's right, exactly. He's drawing the line tracing diagrams. It isn't until we get to the back of the brain that we get the image the right way. It's a wonder none of us are walking in the ceiling. It's really quite amazing. So one of the things that I want to talk to you next, though, is also the choroid. Directly behind the retina is a structure called the choroid. The choroid is the structure of the eye that houses a lot of blood vessels. And it is the blood vessels in the choroid that we sometimes have to worry about disease processes, and in particular, the major disease process of macular degeneration. I'm sure you've all heard of this disease. Has anybody been diagnosed with macular degeneration? Yeah, many different kinds of it. There's certainly the dry type, which is quite common, and then the wet type. The dry type of macular degeneration occurs in about 85% of cases of macular degeneration. The wet type occurs in only about 15%, but is responsible for almost 90% of the damage to the vision or vision loss for all of macular degeneration. So let's start a little bit with the dry type. Let's talk a little bit about dry macular degeneration and what that means and how it actually affects your vision. So the structure in the eye, the RPE, the retinal pigment epithelium, are cells that support the cones. And those RPE cells over time slowly become less and less able to deal with their free radicals, with the metabolites that they produce when they're regenerating the rods and cones. And what happens then is they create waste products. And those waste products lay down in the retina, and they create deposits called drusen. You've probably heard these names before. The drusen are deposits, yellowish deposits at the back of the eye that are created by waste products that accumulate lipofuscin, other proteins, other metabolites that are there, but they're not supposed to be there. They slowly over time accumulate and create gaps in the cells that feed the rods and cones. As soon as you have gaps, and you have less oxygen and nutrients going to the receptors. When that happens, there's a signal that goes to the body, and the choroid is told to produce more blood vessels. Push blood vessels through the RPE cells, and that's when you get the bleeding at the back of the eye. And that's exactly how wet macular degeneration occurs. So it's complex. I've simplified it to very, very few sentences, but that is generally the gist of that very important, very large group of diseases, and they're not all the same. So for example, we start with macular degeneration. We can talk about drusen appearing normally over time. Because let's face it, every cellular tissue in our body over time becomes older. The function becomes less. Many cells in our bodies stop being able to deal with their waste products properly. Are their rods and cones and the RPE so different? No, they're not all that different, except they're critical. When those two layers are affected, vision cannot be created as we know it. So on a continuum of aging, if I was to look into a patient's eye and see a few drusen when they're 60 or 65, is that macular degeneration? Actually, no. That is actually the normal aging process. I expect to see a few drusen here and there. If I don't, then it's a pediatric population, and we don't need to go there. But if I start to see more and more drusen, especially larger drusen over time, or drusen that coalesces and clumps together into soft drusen that are big, and especially if I start to see changes in the pigment of the macula, the central part of your vision, that is also an indicator that the RPE, the retinal pigment epithelial cells, are not functioning properly. Then that means that your macular degeneration of the dry type is going through the stages. There are essentially 4 stages of macular degeneration of the dry type, 1, 2, 3, and 4. 1 and 2 are fairly early, and they're not likely to have a great deal of effect on your vision. You may not even be aware that you have them until I point them out to you on a photograph that we may take of the back of your eye. But in the 3 or 4 stages of the dry type, you may actually start seeing some distortions to your vision. So one of the tests that eye doctors do in their offices is what is called the Amsler grid test. Has anybody seen that test? It's really just a grid test. Essentially a bunch of lines drawn horizontally and vertically, and you're asked to look at it one eye and the other eye and look for any signs of these lines being either wavy or missing or distorted. That could be the early stage of macular degeneration. So that Amsler grid test is an important test. When you're reaching that 3 and 4 stage, we can start talking about the very important AREDS-1 and AREDS-2 studies, which talk about nutritional supplements that can help prevent this type of dry macular degeneration from getting worse, and then switching over to the wet type. So that will be something that we can talk about a little bit later, but I will talk about nutrition generally for all of this as well. So we're going to stop at the retina at this point, and I'm going to move on into the optic nerve. The optic nerve is the part of the eye, think of it as the cable that hooks everything to the back of the eye, the occipital cortex, the vision that occurs right at the back of the brain. And the optic nerve ages as we do. So no surprise there, it gets older. And what the optic nerve carries are cells, the axons that go from the ganglion cells of the retina that take the image to the back of the eye through to the visual cortex. The optic nerve is particularly vulnerable to pressure inside the eye, and we're going to circulate back to the ciliary body a little bit, because remember at the very beginning I talked about the fact that the ciliary body produces this liquid called the aqueous humor, and that liquid is in the front part of the eye, and if that liquid is either overproduced or with the passage of time, aging, not drained properly, then it will build up in the eye and cause pressure on the back of the eye where the optic nerve is. And when that happens, you're going to get excavation of the optic nerve. And by definition, that disease process is called glaucoma. So one of my favorite questions by patients is that when they're coming to see me, they ask for the pressure inside their eyes. Have you had your eyes tested and wanted to know what the pressure inside your eye was in millimeters of mercury? It's a very important reading. But it's nowhere near as important as we like to think it is. Pressure inside the eye is measured in millimeters of mercury. It has a diurnal variation, tends to be higher in the morning, lower in the afternoon. It's governed by a whole bunch of different processes, just like any other biological reading of the body. And what is normal for one person is not normal for another. So we have to think about this particular disease, glaucoma, as being this very important disease that has both a function and a form. So the form part of it is, how does the optic nerve look? When I look at the optic nerve, does the optic nerve look flat? Does it have a little bit of cupping or excavation when there's pressure on it? Does it have lots of blood vessels going through the middle of the optic nerve? Is it really pink, well perfused? Is that optic nerve working well enough that when we do a visual field test, a peripheral visual field test, the vision off into the periphery is working very well, or as well as is expected for age-appropriate normals. And then after all that, I look at the pressure, because the pressure inside the eye isn't as important as how well the optic nerve functions. In an ideal world, we have a very well-functioning optic nerve with normal pressure, but that we know is not what happens all the time in human nature or with most of our patients most of the time. We, in fact, may have an optic nerve which is quite excavated, is not functioning well, is not giving us good peripheral vision, and the pressure is average. It's a nebulous disease. We don't really understand exactly why that matters. So the question that is often asked, what is my pressure, gets a 20-minute answer, because it isn't easy to say your pressure is X, and don't worry, your pressure is average, you don't have glaucoma. I don't know. Not until I've taken a really good, close 3D look at your optic nerve, not until I've measured your peripheral vision, not until I've measured the thickness of your cornea. Because how do we measure pressure? The pressure is usually measured more than one way. It could be a puff of air, very annoying. Most people dislike that. The other way to measure it is to put a little bit of anesthetic on the eye and to use an instrument called a Goldman applanation tonometer, and to press on the eye till you get resistance back and you measure the pressure. I'm sure you've had this done many times, probably each time you have your eyes examined. So that pressure reading is dependent on how thick your cornea is. And the corneas can be measured in micrometers. And if you have a really thick cornea, you're going to get a lot of pushback from that cornea when you press on it. It's like a balloon that's really filled tight with air. You push on it, it's not going to give. If that balloon is not filled tight, it's going to give a little bit more when you push on it. So readings of pressure are not the be-all and end-all, although it's the easiest one to explain. Yes, the question was, when you go for an eye exam and they do the pressure test as the starting point, do they also look at the optic nerve and make sure that it looks healthy, and also look at whether your visual function off to the side is also good, whether you're able to see off into the periphery? Thank you. So the occipital cortex is the last thing, which actually is not in your diagram, but we're going to talk a little bit about what happens at the back of the brain here, and that is actually vision. So first thing it does is the occipital cortex flips it the right way, so we're seeing things the right way. They're no longer upside down. Along the way from each of the eyes, so now we've talked about, I've actually used, for the most part, I use the word singular, your eye, but you have two eyes. So each of those two eyes are signaling to the back of the brain. They're going through the chiasm where it crosses over, and some of those strands of the axons from the right eye go over to the left side, and some from the left eye go over to the right side, and some overlap, and they're responsible for both, and some are only one eye alone, and the whole thing is incredibly complicated, and we see single, fingers crossed. We don't always see single. And the reason for why we don't always see just one image, or maybe we see two images, or an image and a half a ghost, or an image and an upper ghost, is because it's incredibly complicated to get everything together so we see one. On the outside of your diagram, you may have these insertions for muscles. Those are the extraocular muscles. There's 6 of them around each of your eyeball. So if these are 2 eyeballs looking at you, 6 extraocular muscles around each eyeball, and they have to work in tandem. Really hard all day. You know, I thought the eyelids had a hard time of it. They had to go 17,000 times. But think about your eyes and what they do for you. When I look over here and I look over there and I look up and I look down, and they all have to coordinate. I only see 3 of you, 4 of you. No, I see single. I only see 1 of you all the time, right? So all this that I've been talking about how complicated it was from the front to the back, now we come to the visual cortex, and now we have to pull the whole thing together and make it one image. Oh, and somebody moved, and I have to see that. So it isn't just static motion. It's dynamic motion. It's here, it's there, it's everywhere. It's a wonder that we see. It's the most amazing thing, and in fact, it's the most remarkable gift. So when I've gone through that explanation, and somebody says, but it's still fuzzy, it's the aging process. I told a patient today I was going to be giving this talk, and he asked me what the talk was, and I told him, and he said to me, oh, so you're going to be talking about the best before date. There's no such thing, but that's exactly what we have here, is the best before date. Yes, there's that song, If I Could Turn Back Time. Yeah, the question was about a detached retina and a retinal tear, which started the whole thing, and an ophthalmologist doing laser surgery to seal the retinal tear. And how did that happen? Is that your question? Yes. Retinal tears, I used to feel really bad when patients had retinal tears, and I would refer them to the ophthalmologist for surgery, and then the patients would ask me, you know, why did this happen? And I could shrug my shoulders, because most of the time, unless you were hit in the eye and trauma and injury, it's etiology unknown. Until finally, one of the very brave patients who saw one of the leading laser surgeons downtown Toronto came back to me and said, I asked that surgeon the same question, and he said to me, bad luck. So I stopped feeling bad about not knowing why that happened. It's just bad luck. Yeah. Well, when it tears, it's usually just a weakening in the tissue at the back of the eye. Often those tears are in the periphery. So if you're nearsighted to start off with, if you're myopic, if you have a minus prescription, the back of your eye tends to be slightly elongated or stretched or pulled, and the very peripheral part of your retina out on the edges can be thin. And with time, that thin retina can actually develop small breaks. As soon as you get a small break, liquid, essentially blood, goes right into that small break and causes it to lift away from the retinal pigment epithelium. And that's when they do laser to seal it back down. Laser is actually tacking down the retina, sealing it down with these burns, laser burns, which are done fairly quickly and usually can prevent the retina from detaching completely. Because if you have a full retinal detachment, if the central part of your retina comes off, the macula, you actually lose your central vision, right? So having them off in the periphery just as little holes, little tears, is actually okay, because that's doable. Once it's sealed, it's not likely to tear again. It's very much like getting, breaking a bone. Once the bone is healed, it's not likely to be a weaker spot. It might. It's possible. It's possible, especially if the predisposing factor is just high myopia and your retina is thinned all the way around 360 degrees.